So I will go ahead and introduce our session and begin our conversation. First, a huge thank you to all of you who have taken the time to come and be with us today. We appreciate all that everyone in the audience does in the kidney care community, and all of those who are dealing with kidney disease, who are here to learn, to participate, to engage. And we're really fortunate today at this panel on understanding your home dialysis options to have a wonderful panel of speakers, people who are actively engaged here in the kidney community and deeply understand the different home modalities and the things that these can bring to people with kidney disease. So I think we're going to have a really excellent discussion today. I'm going to briefly introduce each of our speakers and then talk a little bit about our topic and then start an open discussion amongst our panelists. And please, I encourage all of you out in the audience, please, as we go through the session, please type your questions into the chat. I'll bring them in. I'll make sure that our panel discusses the issues that are top of mind for all of you, because this really is about the people who are out there who have kidney disease and helping to empower you with information that will be helpful in dealing with your health conditions. So with that, I'll go ahead and introduce our speakers just briefly. We are very fortunate in the Hollywood squares here, directly above me. I'm not sure where he shows up in all of everybody's screens, but we're very fortunate to have Dr. Sean Gage, a vascular surgeon, an expert in complex vascular access, who for many years was the senior operator in the vascular surgery division at Duke University, where he was for 14 some years. He is an innovator and an advocate, interested in improving vascular access, in particular for those who might utilize home hemodialysis at home, and is actively working on projects to help to improve that. So Dr. Gage, thank you for taking the time to be with us, and thank you for being one of our panelists.
Thank you.
I will also then move to the next of the squares with Joanna Lee Newman. Joanna is a great friend and colleague. She has been a nephrology nurse for 33 years, 30 of those years with Satellite Healthcare, a nonprofit dialysis provider. She's held many roles, worn many hats at Satellite, giving her a great depth and breadth of experience, including really deep expertise in both peritoneal dialysis and home hemodialysis. And most importantly, she is a compassionate and caring individual who really provides excellent patient care and has supported many, many other nurses and healthcare professionals in their journeys in providing care to people with kidney disease. Joanna is a regular speaker at national conferences, and we are privileged to have her here today. Joanna, thank you for joining us.
Thank you for having me.
Absolutely. And then I think perhaps of our healthcare professionals on the call here, none is perhaps more expert than Christina Gilchrist, who's proudly living on dialysis and happy now to be helping others to learn how to do the same. She was diagnosed with chronic kidney disease at age 12 and has since experienced every kidney replacement therapy that is available, including kidney transplantation, peritoneal dialysis, in-center hemodialysis, and home hemodialysis, which she is currently using. So Christina, we are really privileged to have you here today. Thank you for joining us.
Thank you for having me.
Wonderful. And then just briefly, my name is Dr. Graham Abra. I'm a nephrologist at Stanford University, where I practice in the Division of Nephrology, taking care of patients with kidney disease in dialysis centers, in the hospital, in the clinic. And I also serve as the Chief Medical Officer of Home Therapies at Satellite Healthcare. And this topic of understanding your home dialysis options is really near and dear to my heart. The home therapies, peritoneal dialysis and home hemodialysis, are really wonderful options for people with kidney disease. They have many clinical benefits. they have many practical benefits, and it's really important for folks to understand the risks, the benefits, what these therapies are, and what they can bring to you, because anyone living with kidney disease absolutely deserves to know what all of their options are and the nuances of these therapies. So I'm hopeful that during our conversation today, we're going to flesh those things out. We're going to hear from all of our expert panelists about these modalities, and we're going to answer your questions, the things that are top of mind for you as you've been on your kidney care journey, and have questions that have bubbled up as you're thinking about these therapies. So I'll go ahead and get us started here. And I'm going to pose the question here first to Joanna Newman, and I'm sure the other panelists are going to have lots of input, thought on this as well. But Joanna, many people at the point that they need dialysis need to understand and know about their different options for dialysis. What do you, as a nephrology nurse, what do you feel is really important for people to know about people's dialysis options at that point where they really need to begin a dialysis therapy?
Okay. Well, actually, I think the most important thing initially is they need to get the option education early instead of waiting for the point that when they need dialysis. Because by the time when they need dialysis, the brain get a little bit foggy, and then they're in shock. So the best way to learn is when they still at about stage 3, 4. And then they need to get to somebody they're very knowledgeable, that can explain to them about all the different options. Hemodialysis, okay, home hemo and in-center, peritoneal, transplant, and no treatment. And it's important for them to understand the pros and cons on everything, and the presenter as a nurse, when we educate the patient or, the CKD patients, we want to ask them what is most important to them. What do they value? How do they want to live the life with the condition of CKD or ESRD? So I think the most important thing is learn about what they want, explore, dig deeper, and say, what do I want? Do I want to just, live for dialysis, or I want to fit dialysis around my life because this is part of my life right now?
Absolutely. I think you raised some really important points. It's so important to, do some self-evaluation, understand, think about what are your goals? What are the things that you want to do in life? And that can help you to engage with your healthcare team around the therapies that might help you meet those goals, because all of them have different trade-offs. I'll kind of put that to Christina. Sort of the same question here from the patient perspective. How do you view this? How did you view it? Obviously, having dealt with chronic kidney disease from such an early age, what were the important things to you in understanding your options for kidney replacement therapies?
Well, I think first and foremost, the big one is all of you guys actually communicating about it. I did almost 5 years in center, and I had no idea that there was such a thing as home hemo. I knew there was home PD, but I was told I was blind, so I couldn't do it. And I did what I was told, because that's what you did back in the day. You did what your doctors told you to do. And then I started hearing from more and more doctors and nurses, and they're actually putting in the time, and they're making life for us so much better. And so at least we can sit down and hear it out and learn our options and go from there, because it amazes me to this day that we've got 3 professionals sitting on this panel, and they're all working for us to make our lives better. And why would we not take advantage of that? So learn your options, know what's out there, because it's important.
Thank you, Christina. I think really, really insightful, and thank you for the kind words. I think all of us as healthcare professionals, we find our roles so fulfilling when we can bring value to the lives of people like yourself who have dealt with kidney disease. And I think there's an excellent comment in the chat here about how some people might think that their life might not have the same value once they have to start some form of dialysis or kidney replacement therapy. And I think that's not an uncommon sentiment. It is a huge life change to have a critical organ no longer work and have to take on a life-sustaining therapy or an organ transplant. That is a really psychologically difficult thing. And I think it's important for people to realize that life isn't over. It's going to be different, but it can still have value and it still can be really fulfilling. Dr. Gage, from a surgical perspective, you obviously see many people with kidney disease at the start of their dialysis journey, where they're weighing their options for dialysis and thinking about what sort of access option they might be, whether that be a blood-based vascular access or perhaps a peritoneal dialysis catheter, if that's what they're opting for. Could you give us a little bit about your perspective as a surgeon, what's important for patients to understand at the start?
Yeah, so there's a lot to consider, and this is a very complicated space, even for those in medicine and in surgery. And so to think about it from the patient perspective, it's got to be extremely overwhelming when patients come to see us. And that's something that I always try to keep in perspective. And so first, I'll sort of answer it for any of the clinicians that may be out there. And, one thing that I think is very important is, as we should do in all respects of medicine, it doesn't matter what it is, but we should strive to ensure that our patients have no more questions before they leave the room. And when it's something this complex, you need to make sure that every question is answered. And it's hard to do, right? We've got a lot of people in clinic. I'm usually behind and people are frustrated, but this is a really important thing. And so we need to make sure that patients understand everything before they leave. And that really requires breaking things down, really breaking things down. I'm a vascular technician. It's tubing and conduit, but it's with, human body parts and tissue. So it's a little complicated in that way, but it's all really a very technical, I think about this, this similar way of how I fix my car or how I build something with wood. It's all very technical, or doing any plumbing, but you have a patient's life in your hands. And so to me, it's very simple to think through it, but for a patient to try to break it down, they don't know what things look like on the inside of the body. They don't know what to expect. And so anyway, so from a clinician perspective, that's some advice that I have. But for the patients, I think that it's really important for us to lay out from the very beginning that this is potentially going to be a lifelong journey, one way or the other, whether it's with a kidney transplant, or whether it's peritoneal dialysis or hemodialysis. Either way, it's a lifelong journey. And so they need to have that understanding. And when it comes to the areas of my expertise, which is not kidney transplant, but surgical, in terms of hemodialysis access or peritoneal access, you need to, as a clinician, you need to think into the future. What's that life plan, and how many options is a patient born with, right? And you're really only born with a finite or a certain number of options until you're done. And then things get really, really complicated, or it makes it more likely that somebody could die when they lose their lifeline for access. So to make sure that patients understand that from the beginning, so that when you're talking about things like, well, I may not want a fistula in my wrist because it might look a little ugly, which I completely respect and understand, and that's something we negotiate about. But on the other hand, when it comes to your life, is it worth burning an option that could have given you another 3 to 5 years of an access plan? And so it's, you got to get real with people and say, like, here are the options, and it's my job to make sure that we use all of those options as efficiently and effectively as we can to go over the entire lifespan for a patient. So.
Yeah, thank you for that. I think incredibly important to think about.
Can I jump in for a sec?
Absolutely, Christina, please.
Okay, so I think everything you said is so true. And I think as a patient, I hear all the time, it's going to be hard. I don't want to have to store things, like I challenge you. People go to school for a career for how long? They invest how much time learning how to do their day-to-day job? Is our life not worth that? If you are not willing to put in that time to make your life better and make your life extended and the best it can be, then you're just being silly. And yeah, it's not going to be pretty. Like they were saying, the fistulas, they're not pretty, but you're tough. You got to just say, hey, my life, this is it. I've got to handle this, and I got to step up. And this is the new job. Invest time, learn your options, learn what your doctors are saying. And if you have a doctor that's willing to talk to you and take the time, pick their brain, take this on like it's your career. Because from now on, it's your life.
That's wonderful. Important, really.
Yeah, you got to go into battle mode a little bit, and you got to rein it in. You got to take control of yourself, and then as you're doing that, then you make it part of your life. You live your life, you do your normal things, and it all becomes hopefully all becomes commonplace, and it's just part of what you do every day. But it really does require that you taking the bull by the horns up front, and every time there's an issue, and be an advocate for yourself with your clinicians to protect yourself for your life.
Excellent points. We've got a really nice, insightful question from Charlie in the audience who, asks about how limiting dialysis is when it starts. And this is I think a common sentiment for a lot of people who are facing this issue where dialysis is going to begin in the near future. And they really, people want to understand how does your life change when dialysis starts? And maybe I'll start with the nursing perspective from Joanna, and then we could go to the patient perspective from Christina. So Joanna, from your perspective as a nephrology nurse, how do people's lives change when dialysis begins?
Okay, so I don't have kids, but I think for the audience, whoever have kids, know when you have a newborn baby, your life changed. So dialysis is the same. You have something new fit into your routine. It's going to change. It's going to be different. You have new responsibility and commitment. However, one thing that I want to share with you, that the reason why I have been in dialysis for 30-something years is the satisfaction and joy to see patients getting better from before they start dialysis to after they start dialysis. And in a week or two, depends on what modality to choose, you can see that the energy comes back, the color comes back, the cognitive comes back. So it's going to take a little bit of adjustment for sure. I'm not going to lie to you. It's work, it's labor. Well, not that much, but you learn to fit that into your lifestyle, and then heavily depends on what kind of modality you choose. Okay, and that will affect your diet, how well you feel, and subsequently your activities.
Yeah, very good points. Christina, obviously having lived through these things, how did your life change as you began various types of dialysis?
Well, it's incredible how different you feel on each modality. And so that in itself has a lot to do with it. Whatever you choose for your dialysis treatment, it has different variations of how you feel. And I feel like we all in our lives, we want normal. Everyone is like, I want to be normal. I want to be normal. Well, I have my new normal. This is my normal. It may not be someone else's, but it's mine. And it involves doing dialysis. And I feel better when I do dialysis. I think, especially when you're first going into kidney failure, we put it off. We try to go as long as we can without getting on that machine. And sometimes that's not always the best thing for you. You're putting so much pressure on your body. And if you slowly start working into one of these modalities with your doctor, you're going to feel a lot better. The transition's going to be a lot easier, and you're going to feel better going through that transition. So I truly recommend sit down with your doctors, talk about which path is right for you, and don't push it off until you're to the point where you absolutely have to get on that machine.
Excellent points. Excellent points. I think important to this session, about understanding the home modalities and your options with them. Perhaps we could all talk a little bit about peritoneal dialysis and home hemodialysis and what the advantages and disadvantages of each of them are, because nothing is perfect in medicine or in life, really. And all these things come with their pluses and come with their minuses. And it's really understanding what those things are from a clinical perspective, but then also from a practical and how does it fit into your life perspective. Dr. Gage, maybe I could begin with you just from a practical perspective, the basic difference between a patient who's going to want to do home hemo versus a patient who wants to do peritoneal dialysis in terms of the surgical procedures and access that they might need.
Yeah, let me see if I can utilize a little screen share to pull up here, just to kind of to share what I'll explain. Let's see if this will do it. There we go. I think this. Okay, can everybody still hear me?
We can.
Okay, great. So just to illustrate, and for those who don't know, this is just a very brief overview of hemodialysis options. Hemodialysis means that you are cleansing your blood directly to replace your kidney function. And in order to do that, you need to have a high flow dialysis shunt in order to be blunt, to literally suck out the unclean blood and it to go through a machine and clean it and then push back in the clean blood. And you can't just do that with a regular old vein in your arm, because a regular old vein in your arm, flows, has a very low flow. Let's say 30 to 50 milliliters per minute. That's very little. In order to perform hemodialysis effectively, you need to have something that's flowing at least 500 milliliters per minute, roughly. That's half of a liter per minute. So it's a lot of flow. In some of the shunts that we put in, they flow over a liter per minute. So it's a lot of blood flow in order to be effectively clean your blood. So a regular vein won't do it. So in order to do it, we have to either hook one of your veins in your arm to an artery. As you can see here, it's a small picture, but when we hook that vein to an artery, all of a sudden it starts to flow at a very high rate. And if that vein can grow enough, you can poke 2 dialysis needles into it to do your dialysis. Another option is a graft, where we have to put a piece of plastic tubing under your skin and connect it to an artery and a vein. And that tubing becomes the conduit that you poke the needles into to receive your dialysis. Generally, a fistula requires one small incision, either kind of sort of at your wrist or near your elbow. And it's an outpatient surgery. You go home the same day generally. A graft surgery requires 1 or 2 small incisions, little cuts, usually near your elbow or your armpit, and your graft goes over your bicep or your forearm. And then there's another option for hemodialysis, which is an external dwelling catheter. So this is a catheter that we poke a needle in through the skin in your neck, and it goes directly into a large vein in your neck. And the tip of that catheter ultimately ends up right at the top part of your heart, the what's called the right atrium. And that catheter tip sits there, and it can suck blood in one port, the unclean blood, and it can push the clean blood through the other port. But one of the unfortunate things, you have to have this catheter that hangs out of your skin onto your chest. A lot of patients like it because you don't have to be poked with a needle. That's very that's something that a lot of people like about it. But unfortunately, what clinicians don't like is that it puts you at a higher risk for an infection, either at your skin or in your bloodstream. And so generally you'll hear from nephrologists or surgeons that we don't want you to have one of those catheters in. They serve the purpose to get hemodialysis, and if that's all you can do, that's fine. It's better than nothing, but it's generally our lowest preference because of the risk for infection. And generally it doesn't provide as good of hemodialysis as a fistula or a graft. So that was just really quick about that. And I can answer more questions about that. But I did also want to then give you just a visual of what's peritoneal dialysis. Well, peritoneal dialysis utilizes the membranes inside of your abdomen, basically where your guts are, where your intestines are. And we can utilize fluids, dialysate, that we pump into your abdominal cavity. And it kind of gives you, your belly gets a little full. And then over the course of time, those fluids do the exchanges with your electrolytes, and it helps to perform your kidney function essentially. And what that so it is not it is not using your blood access directly. It is using the fluids in the membranes in your abdomen, in your stomach area. And this is what the catheter kind of looks like. It goes in through just right through a poke hole in your abdominal wall. And this is just kind of a crude view of it, but you get this little we call it a pigtail catheter, and it kind of curls up down there, kind of underneath your guts. We don't want it to be stuck inside of your intestine area. If it gets all kinked up or it gets covered by your intestines too much, it won't flow very well. So we have to really try to place it in the right spot so that it works well. And generally it's kind of down here. And from a front view, this is sort of where it looks like. We try to make the exit where the catheter actually sits outside of your body. We try to make that kind of towards the left or to the right of your abdomen. And it just kind of depends on if you have a preference generally, one side versus the other. But it's just a small little catheter that kind of sticks out of your abdomen. It's a very soft, flexible catheter. So generally people do very well with that as well. So that's just a high level overview of the options. And it really gets down to, I would say, your nephrologist generally, and you as the patient, as to one, which modality may work best for you, because every patient's a little bit different. Some may not be very good candidates for peritoneal dialysis from an overall kidney function in general. But there are also physical things, like if you're extremely overweight or obese. Those are things that generally your surgeon is going to talk to you about, and you may not be the best candidate. Or if you've had multiple abdominal surgeries and you have a lot of scar tissue in your abdomen, generally you may not be a good candidate for peritoneal dialysis. But generally the patient and the nephrologist usually will, in my experience, have those discussions first about what modality might be the best. And then you come see me, and we talk about the nuts and bolts of, like, all right, what's it going to be like? What's our game plan for doing the actual surgery, and in what order we do it?
Really, really nice overview. Thank you so much for that. I will just say, larger patients absolutely can do peritoneal dialysis. I'm sure Dr. Gage, has assisted patients with options for peritoneal dialysis catheters that can help patients that have, say, a larger belly. Sometimes the peritoneal dialysis catheter exit site can be placed in the upper abdomen, or sometimes even higher up near the chest, the sternum, which can be very helpful for the larger patient. And patients like that absolutely can thrive and do well on peritoneal dialysis. Similarly, patients who've had abdominal surgeries, it's an excellent point that sometimes there can be scarring, adhesions within the belly because of those surgeries, but great surgeons, at time of catheter placement, can also often lyse those adhesions and successfully place catheters, and people like that can do well on PD.
We have better options for that now than we used to. Now, especially a lot of catheters are peritoneal catheters are placed what we call laparoscopically. like we would do laparoscopic gallbladder surgeries and things. And so then you can really visualize. You can take, like Dr. Abra was saying, you can take down some of those adhesions or that scar tissue at the time. So we do have far, than 20 years ago, 25 years ago, it was much, we really couldn't do that. And it was a blind procedure. And so now we have a lot more control and a lot more options for sure for peritoneal dialysis.
Excellent point. Let me bring in a question from the audience here. Christina, perhaps you could take this one. It's a question from Jackson about the types of changes that you experienced personally in changing dialysis modalities. I'm not sure if you went from in-center to one of the home modalities or some other pattern. Perhaps you could talk a little bit about your own experience with that and how you felt in using the different modalities.
Yeah. So first and foremost, I did want to say I've had a fistula, I have a graft, I have a CVC that's in right now. I did have a PD catheter, and I had a catheter placed in my chest. And so these things are all real options. So truly, sit down with your vascular surgeon and take the time to really discuss with them. And I had my first fistula when I was 24, and I didn't talk to my doctor about it. He placed it in my upper arm. And so now that I'm older, I realize that, shoot, why didn't we try to go wrist? Why didn't we try to put that lower to try to maintain some access points on this arm? And those are things that you kind of learn the hard way. If you don't know to sit down with your surgeon and say, hey, I need to have options for the rest of my life. So let's make it as forward thinking as we possibly can. And so I didn't know those things. And so I just let them do what they wanted. And that's something to be aware of. And if you have an amazing vascular surgeon, they're going to give you those options. But if you happen to get one that's just kind of busy and wants to just get it done, you got to know your options. So that's super important. And I started dialysis with in-center, and I kind of kicked myself in the butt for it because I was a single mom, and my daughter was, I think, 5, 6, 7, just really young. And I feel like my entire life was a fog. I don't remember much of it. I was just doing whatever I could to get from day to day. I wasn't enjoying life. When I started PD, it was dramatically different. I felt like my life was given back to me. It was like this gift that I didn't expect. And it opens up so many opportunities for getting out of your house, going on vacations, just doing your priorities. And then I was forced to go to home hemo, and honestly, now I don't know why I didn't do home hemo to begin with, because that feels even better than PD. So I think that, of course, your hemo, the effectiveness on cleaning your body is top priority. And so home hemo, and I'm actually really excited because I'm going to do nocturnal. I'm starting here in a couple of weeks, and home hemo is the closest you're going to get to feeling great. And for me, home hemo, and I don't think I would ever go back to PD. I think PD is a great first step because you don't have to learn nearly as much. But I definitely think being on hemo opens up your options to feeling as good as you can with no kidneys.
Absolutely. And Dr. Gage, I see you have a slide up here. Did you want to just briefly touch on the sites of potential vascular access for the audience?
Yes. Yeah. I figured since Christina brought it up, I thought it might be a nice time to share. She'd said they started in her upper arm, probably a brachiocephalic fistula, which is generally here just above your elbow or where the bend of your elbow is. And it's a really good point. And that's one of those things I kind of talked about early on about understanding your entire, life plan. There's the vascular access life plan that I think of it as well that we talk about, because again, if you start up here in your upper arm, you may burn the options to have these potential fistula options down in your lower arm or your wrist. And again, every site, is in my mind is very precious, because that may add 1, 2, 3, 5, 10 years to, your life, if you don't squander them. And so from a clinical perspective or clinician standpoint, one of the things that I'm always teaching residents or other clinicians is to really think that through. This is not just what's the option for next week or next year. This is what's the option over the life. And so if you start at the wrist and this option and it fails, and it flames out miserably, you can then march up the arm and use the other potential sites. But there are only a few potential sites in each extremity. There's 2 to 3, maybe 4 if you're really creative and you have the appropriate anatomy or your blood vessels are usable. You could have 3 or maybe 4 fistulas in each arm, maybe. And again, that's at max. And then you could have a potential for maybe 2 or 3 different types of grafts in the arm. Again, maybe. It just depends on your anatomy, or if anything else has gotten scarred over the life of use of your fistula or your graft. There are also a couple of options in your thigh that we can use, 1 or 2 in each thigh. Again, maybe, and it depends on if you have, blood vessel disease in your legs, if you have narrowing of your arteries and things like that. So a lot of things we need. And then we can if things get even more complicated and dire, we can look to putting certain types of grafts in your chest, or other complicated ones that get through narrowing or blockages of the veins in your chest, that I used to do, unfortunately, a lot of, because that's a big problem. And so, it looks like there are several options here, and at max, there could be several options, but generally every patient's different, and you only have so many potential options, maybe 5 to 8 options over the course of your life. So it's very important as a clinician to salvage each and every site. And so it's very important for us to communicate to you as patients why that's so important.
Yeah, thank you for that. And just to address some of the really excellent discussion that's going on in the chat here, it's a really nice question about, if home hemodialysis is still hemodialysis, why does it feel any different than if you do dialysis in the center? And I think this is really quite an insightful question. If you just change the setting, what does it matter? And I think, at least from my perspective as a nephrologist, part of it is you add in flexibility, right? When you go home and do home hemodialysis, it means that you are in charge of the time and the schedule based on the outline of the prescription that your nephrologist and healthcare team has done. But you can decide, am I going to do it in the morning? Am I going to do it in the evening? Gosh, am I going to do it overnight like Christina is going to do in the near future here? And that flexibility is huge. And it also frees you up to more easily do more frequent dialysis. That's sometimes a little more challenging in the clinic where, space and time can be limited. But doing more frequent dialysis at home can be gentler, can remove fluid more slowly, can provide more clearance of toxins, and people oftentimes will feel better with these things. And that can be a little counterintuitive, I think, particularly if you've been on in-center and you've had the experience of feeling poorly after dialysis. You kind of think to yourself, why would I do any more of this? And part of the issue is that when we try to get it all done in, let's say, 3 to 4 hours, 3 times a week, we're really stressing your heart, we're stressing your body. And if we can do dialysis more slowly, more gently, oftentimes we remove that side effect or lower that side effect so people can do better. So I think it's a really nice question. Joanna, I want to put to you, there's another nice question from the audience here around peritoneal dialysis, asking around, so peritoneal dialysis, it's a bloodless therapy, right? You don't actually need to put needles or access a blood catheter to do PD. Could you describe it a little bit, how fatigue after dialysis might be different between PD and, say, center hemodialysis?
Okay, so I will say peritoneal dialysis, we utilize fluid and indirectly kind of clean the blood. Instead of hemodialysis, we have the fistula, we have the blood coming out from the body, go through the dialyzer, the filter, and then bring it back. And for any hemodialysis session, except for Christina, what you're going to go to do, nocturnal, it will be a longer period of time. A typical hemodialysis session is like 3 to 4 hours. So you are trying to clean the blood in a very short period of time. Versus for peritoneal dialysis, we have the fluid in the peritoneum 24 hours a day, 7 days a week. So our blood gets continuously cleaned round the clock that resembles our normal kidneys function. So with that said, without a strenuous removal in a short period of time, the patient has a lot less recovery time or no recovery time because your blood gets clean at all time.
I think
Can I add some?
yes,
Yes,
please.
So as a patient, and especially after doing in-center for as long as I did, I know every single patient right now is thinking, you want me to do more dialysis? No freaking way. And it's insane, but once you slow that machine down and you are on top of your fluids more, and it's amazing how much gentler it is on your body and how much better you do feel. Even I run 4 days a week, 3 hours a day right now, which gives me 12 hours, which the average person gets 168 hours of kidney function. Someone with good kidneys, 168 hours in a week. I get 12, and people in center usually average about 9 to 12 as well. But the difference is I'm doing it more often. And so my body doesn't get to the point where we've got to suck the life out of it to get this blood clean and to get this fluid off. It never gets there because it's always at a mild point of we just need to pull yesterday. And so it totally is different. I can do 3 hours and I can see somebody in center do 3 hours. And afterwards, I'm going to go to the gym. I'm going to go work out. I'm going to hang out with friends. And that person in center is going to be exhausted because that machine knows it might be a weekend and you're not coming back again the entire weekend. So it just sucks you dry because it has to, because you can't go that long without kidney function. So I know it's hard to understand, but the idea of more dialysis is tough. But once you do it, you will never go back.
Yeah, it's a very nice point, Christina. And Joanna, you have your hand up. Go ahead.
Okay, so, for the non-clinical personnel like patients, I usually describe peritoneal dialysis as you soaking some, say, dirty clothes. We put the fluid in the peritoneum, the toxin, the waste product slowly diffuse, gets soaked into the fluid, and then you drain it out and you put new fluid in. So it's like you're washing clothes, right? You put the clothes in a bucket of water, you let it soak a little bit, and then you wring it off, change new water. Same principle. And then when we use the machine on the cycler, it's like, okay, now I go step up to using a washing machine. You put all the dirty clothes in, and the washing machine will clean the clothes for you automatically. Drain the water, put new water in, and clean it. And imagine if you go to in-center, you have the same amount of dirty clothes you have to wash, but you squeeze all the dirty clothes for you to wash by hand. Imagine that you're washing by hands. You're going to feel really tired versus if you just clean 2 pieces of t-shirt, 2 t-shirts a day, every single day, you feel like, oh, that's not bad, versus you have to wash 10 t-shirts by hand every other day. It's just similar analogy, and that's why if you do it more frequent, you actually will feel better and less tired.
Thank you for that, Joanna. And many in the audience are relating their own experiences with the tiredness, the washed outness that many people do experience after hemodialysis. particularly in center when it's done 3 times a week. Now, not every person experiences this, but many do. And it can be a really debilitating thing for people. I think that's coming across really clearly. I think it's also important to highlight, though, that when you dialyze more frequently and you're accessing, if you have a fistula or a graft, if you're putting needles into that fistula and the graft more frequently, it is well understood and known that you are at slightly higher risk for complications to the vascular access because you're putting the needles in more often. And there's a question in the chat about that. And this is known. It is one of the trade-offs when you're using that vascular access more frequently. So it's really important to get excellent training around how to access that vascular access so that any damage really is minimized. And there are different techniques for how to access fistulas in particular, and grafts. So it's important to understand those options from your healthcare team and your surgeon. I don't know, Dr. Gage, if you'd like to mention briefly about the different options for cannulation and accessing grafts and fistulas.
Yeah, for sure. I saw that there were a couple of questions about differences between fistulas and grafts, so I thought I would just quickly show that to clear that up, and then I can explain further about cannulation. But a fistula is, again, where you take your own vein that you're born with, and we sew it through a small incision here in your wrist or your elbow. We can sew it directly to your artery. And then that blood, some of that arterial blood that's going to your hand then goes right up into the fistula. Generally, most people do just fine with the blood flow to their hand, despite that this is stealing some. But that's generally a fistula. So we're sewing your own vein to your artery. And this is an example of a really nice dilated fistula. Most don't look like that. But that's sort of what it looks like. And here's where we made the connection between the artery and the vein right here. A graft is something that we put a piece of tubing under the skin, and we hook it to a vein, and we hook it to an artery. And this is an example of a forearm graft, a forearm loop. And then we stick the needles into that. And here's just some examples of different configurations we can do in the arm. But again, this is all under the skin. And so it really it gives us a lot more options. But to the point about vascular access or needle access in puncture, absolutely, the more times you puncture a tubing, the more trauma you're doing to it. Now with a fistula, because it's your own tissue, it had the benefit of actually healing itself. The little platelets that clump up our blood and stop us from bleeding, they plug up those holes, and then the fistula actually heals itself. But rotating the sites, sticking a centimeter or so away from each puncture zone helps that healing process to be more effective. Which is the cannulation training of not sticking in the same spot is extremely important. But also not injuring the vessel by sticking the needle all the way through the front side and through the back side. That's another option. That's another aspect of injury that can lead to problems. But for a graft, that is not tissue. It is not tissue that heals. A piece of Teflon graft made of polytetrafluoroethylene, very long word, but we call it PTFE, is the most common form of graft used today. And when you stick a needle into it, it's just like a styrofoam cooler that if you were to poke a screwdriver into the side of it and you pull that screwdriver out, it has a hole in it, and it doesn't heal up. And so you really rely on putting pressure on that graft with your finger the right way and allowing those platelets to plug up that hole, along with some scar tissue on the outside of your graft, to stop that bleeding. But you're always going to have those platelets clumping up that part of the graft. And that piece of graft that you stuck the needle into, it's going to be missing. And so if you do that over and over again, that graft can turn into Swiss cheese, and it can start to dilate into what we call these pseudoaneurysms, or bumps that people call. And those things can get dangerous, and they can get infected, or they can bleed. And so being on home hemodialysis it's another big consideration of the long-term durability of access. And I have to then interject one of the things that I've developed is to exactly help to fix that problem. And it's a graph that we're working on with my company Innovask that's now been acquired by Gore, W.L. Gore and Associates, and we're continuing to work on it. But what we have are 2 cannulation pods, 2 little zones that are meant to be stuck with a dialysis needle, to where you can't poke through the backside, you can't cause that back wall injury because of the way that it's developed. And on the front side, because of the materials, it doesn't bleed when you pull the needle out. And so it's a self-sealing type of cannulation pod, but it's a more durable pod. So if we're talking about home hemodialysis, and now instead of doing 3 days a week of dialysis, you're doing 5 or 6 days a week, maybe 7, that's a whole heck of a lot more needle punctures per year that you're doing. And so we need to start to talk about more durable graft options for people to get home, because again, not everybody can have a fistula, or you run out of those options. So eventually you may have to have a graft. And how are we going to solve that? More frequent cannulation. We need better technologies to handle those areas. We need technologies that are actually meant to be stuck with a needle. And so that's part of what we're working on currently. So.
Thank you for discussing current state and possible future. Christina, could you talk a little bit about what people should expect during their first year of doing dialysis? What are some of the common things that people should be aware of as they're beginning dialysis on any of the home modalities, either PD or home hemo, that are things that perhaps you might not necessarily know, even from talking to clinicians or reading about things online? What are some of the top things that you wish you'd know as you were going into your first years of peritoneal dialysis and home hemo?
Yeah, I think the biggest thing is give yourself a break. You're going to have times that it's going to be scary. You're going to have times where you and your nurse are talking very frequently. They're going to happen, and there's a way to handle them. Give yourself a break. Don't expect yourself to be perfect. Don't expect that you're going to like this process, because we're still doing dialysis. We're still doing treatment to clean our blood. And so that's not going to be it's never going to be a peaceful, lovely thing. Yes, I get to do it in my bed, in my comfortable bed, and that's awesome. But I'm still doing dialysis. And outside of dialysis, don't push yourself to be the person you were before. Push yourself, definitely, but understand that your body's going to have different limitations, and push them, but don't force yourself to be that person you were before. Take some time, give yourself a break, and just take it as it comes.
Yeah, I think that's very wise and important for folks to realize. Joanna, let me ask you, because I think it's important to kind of summarize a little bit as we come to the top of the hour. How can people make the best decision for them, in particular around the home modalities, peritoneal dialysis and home hemo? What are sort of the key things for them to understand and to know in making the best choice for them?
Okay. Well, I think there's nothing better than to see one and talk to the existing patients. Okay. And a lot of the dialysis center nurses can help you find somebody that kind of match your background. And then most of the patients, Christina, you can correct me if I'm wrong, most of the patients are very willing to share their experience. Find the patients that have done hemodialysis, peritoneal dialysis, home hemo, and then if some of the people will even invite you to the home to let you look at the setting. So nothing is better by looking and touching and feeling per se, and then listen to what they say, how that affect their lifestyle, what is important, and then go back to thinking about what is important in your life. I want to continue to work, or I want to see my grandkids graduate. I want longer life. I want to feel good. I want to stay active. Or, you know what? I'm not at a point that I can deal with anything. Just stick the needle in me, let me go in and do. That can be an option too. But one key important thing is we know that dialysis journey is a journey. Okay, a person like Christina can experience all different types of therapy throughout the journey. And even we start at one that is the most appropriate for your lifestyle right now, your life right now, it doesn't mean that down the road it can be the best. You might have to change. So we have to be open to change according to what our health status is at the moment and what our lifestyle is.
Yeah, thank you. Thank you for that, Joanna. Um, Christina, do you have some parting thoughts around home therapies that you think are critical takeaways for the audience?
Yeah, so for me in particular, when you go into kidney failure, when you hook yourself up to a machine, whether someone else is doing it or you're doing it, you know, you lose a lot of your independence. And that's hard. And the only way to get that back is to take back some of that responsibility. Going home gives you some pride. It gives you to where I can sit down with professionals now and have a conversation about my numbers and actually be actively participating in my care instead of being told what I need to do. And so I think understand that, yes, it will be a little work and you're going to have to do a couple things you just don't want to, but you will have control again and you will be able to get on top of your own treatment and know when you're at home, okay, this just happened. I know what I need to do because I know my numbers. I know I flow at 350. I know these things. And so I therefore can make dialysis work for me better because I know which speed I feel best at. I know how much fluid I can take off as a max and still feel okay. You get back not only a bit of your health, but your independence is key. So truly take the time. And I know I was at a point where I went to a center and I just wanted them to stick the needles and I wanted no responsibility. And so it truly does. There's a time and a place for in-center and there's a time and a place at home. And just if you are willing to take on a little responsibility, you will be so grateful you did.
I think those are really excellent. You know, there's a time and a place for each of the therapies, and you shouldn't feel, you know, less than if you're using one particular type of a therapy versus another. All of them are perfectly appropriate at given times. And I think the one of my take-home messages from the session today is having that understanding of what these different things are and how they may fit into your life is really what you want to try and achieve versus.
I kind of just want to say I was at a center that didn't have home modality options. And so I think that's a big part is check out your centers that are around you. Check out what machines they got. Check out what's going to be the best clinic to offer you the best. Because we have these centers now that they're putting the work in. They're putting the time in. They are finding out which machines. They're finding out all these things for us. And if we're at a clinic who's not, take the time and find one that is.
Wonderful. Thank you, Christina. Dr. Gage, do you have any parting thoughts here as we wrap up?
Yeah, I mean, I can't stress enough, you know, you got to advocate for yourself. You got to, no question is a dumb question. Make sure that you get all of your questions answered from your clinicians. Clinicians out there, please try to think from the patient perspective and what questions they may have as not being an expert in surgery or dialysis access, so that everybody is as informed as they can be. Because again, this is a lifelong journey here, and we all need to take it very seriously to make sure that we're just doing the best for the patients as efficiently as we can.
Absolutely. And I think, you know, our audience has taken a wonderful step today, particularly those who are dealing with kidney disease, in coming and learning. You know, learning is not a one and done process. It takes, you know, I had an old pathology professor who used to say, repetition is the branding iron of knowledge. And it takes us many, many repetitions oftentimes, particularly to get these complicated things that take years to understand, even for medical professionals. So you guys have taken a wonderful step in learning, and I encourage you to continue on that journey and become experts in dialysis care and these different types of therapy, so that you can make the best decisions for yourself, and you can help others as well if that's going to be part of your journey down the road. So thank you all so much for attending. Thank you to our fantastic panel. Thank you to the American Kidney Fund and our sponsors, Home Dialyzers United. We really appreciate the opportunity to engage with all of you, and thank you all for your time and for coming.
Thank you all. Take care.